I'm Berdahl from Vance Thompson Vision in Sioux Falls, South Dakota. And we're going to be talking about new thoughts on glaucoma management and why this matters in the first place. And when I say new thoughts, I mean really new thoughts. And I purposefully have made this presentation so that we can have some really good time for deep, good questions at the end. This data has a tendency to make people think differently and real deeply about glaucoma, what it is, and new treatment options for it. So along the way, keep in mind that we want you to be writing down your questions so we can talk about them at the end. Here's my financial disclosures. The most pertinent one is Equinox, although I do consult for a lot of glaucoma companies. We'll mention some of the approaches that we're trying to take with a company we developed, Equinox, here a little bit more in a detailed way. So this all started when I was scuba diving with my family, and this is my son, and that's my wife, and that's me down on the left. And about 12 years ago, when I was a resident, maybe even longer than that, 13, 14 years ago now, boy, the world keeps spinning. I was down just 30 feet scuba diving, and I thought, what happens to my eye pressure down at 30 feet with all the weight of this water pushing on my eye? Because if you're a scuba diver, you know that at 30 feet, that's 1 atmosphere of pressure. 1 atmosphere of pressure is 760 millimeters of mercury that gets added to the pressure in your eye. And I thought, how is it possible that I don't have the signs of acute angle glaucoma? How is it possible that my optic nerve head could be perfused if my blood pressure is only 120, but my eye pressure is 760? There must be some bigger picture that I'm missing. And so instead of enjoying that one vacation that I got as a first-year resident, I was sitting on the beach thinking about what could be going on in our bodies when we scuba dive. And that led me to believe that it's not just the eye pressure that matters, it's all the other pressures in the body that matter too. And so when we're down 30 feet, our entire body is pressurized by an additional 760 millimeters of mercury. So it's the relative pressures in our eye related to the surrounding atmosphere, which is the weight of the atmosphere plus all the weight of that water around our entire body that matters. And hence it's the pressure inside the eye relative to the pressure behind the eye that matters. And so I excitedly come back to my residency and talk with one of my professors, Rand Allingham, who's one of my real heroes in ophthalmology. And I say, I think I figured out what glaucoma is. It's a balance between intraocular pressure and intracranial pressure. And he says, I don't think you're right, but go study it. What a great answer. There's a skeptical part of it, but he says, I'm willing to be wrong. Go get the data to prove it. And so I did. I went to the Mayo Clinic where I did my medical school, worked with Doug Johnson, who was one of the really great people, great innovators, and giant intellects in glaucoma. And we looked at 55,000 people that had had lumbar punctures over a 20-year period, identified which ones had eye exams, and of those who had verifiable glaucoma and who were we able to verify didn't have glaucoma. And we compared their CSF pressures. And we ended up publishing this in Ophthalmology in 2008. And we found that people that had glaucoma had a lower CSF pressure than people that didn't have glaucoma. In fact, the average CSF pressure of the control group was about 13 millimeters of mercury, and the open angle glaucoma group was 9.2 millimeters of mercury. And we published that in Ophthalmology. And then we said, well, if that's the case, I wonder what happens with people that have normal tension glaucoma. So if glaucoma is an IOP that's higher than intracranial pressure or CSF pressure, then maybe normal tension glaucoma patients would have an even lower CSF pressure. And it's that pressure differential across the optic nerve head that matters. And so we looked at that, and indeed we found that patients that had normal tension glaucoma had an even lower intracranial pressure. Now, in our study, it wasn't that much lower compared to a control group of 11.8 millimeters of mercury. We also found out that people that had ocular hypertension had an elevated intracranial pressure that was likely protective of glaucoma, because remember, these ocular hypertensives didn't necessarily get glaucoma. So when you think about this, it steps out like this. Normal is an intraocular pressure and an intracranial pressure that are pretty closely related. Most people with ocular hypertension don't end up getting glaucoma. They have a high eye pressure, they don't get glaucoma. That's probably because they have a higher intracranial pressure that's protective. Then you have regular glaucoma, high eye pressure, low intracranial pressure. There's a pressure differential and you get the disease. And then you have normal tension glaucoma, high pressure, but a really low intracranial pressure, and that differential still exists. So we go and we get this information, and I remember driving to the airport, calling Rand Allingham saying, hey, here's what the data looks like. He said, John, I was thinking about you today. I just about fell off my chair because I had a very well-controlled glaucoma patient that got a cerebral spinal fluid shunt, and that CSF shunt lowered their intracranial pressure, and then their glaucoma got worse. So we come back, and Dr. Allingham and I are excited about this. We share it with our chairman, David Epstein. And boy, did the questions just start flying, and was he excited. And if you knew him, you knew that when he got really excited, he'd get a little foam in the corner of his mouth, and he was inquisitive, and he was a scientist, and he was great. And the questions started flying, like, what happens to IOP with age? What happens to intracranial pressure with age? Does diurnal variation matter? And so I'll ask you virtually, there's no way to signal this right now, but what does happen with IOP with age? Ask yourself that. Do you think it goes up, goes down, or stays the same? Now pause, think about it, answer it to yourself honestly. What happens to IOP with age? It turns out that IOP decreases after age 60. It goes up a little bit until age 60, but after age 60, it starts to go down. But what happens to the incidence of glaucoma after age 60? It goes up. So glaucoma incidence increases, but IOP on average starts to go down. This is from the Blue Mountains Eye study. After adjusting for blood pressure, there is a trend for IOP to decrease with increasing age. Now, what happens to intracranial pressure with age? This is another study that we did and we published. This curve has 14,000 data points in it. And what it shows is that right at around age 65, intracranial pressure starts to go down relatively dramatically. Now, if we take a step back and we think about this, glaucoma goes up with age, IOP goes down with age, intracranial pressure goes down with age. It seems like one of the reasons why there's an increasing incidence of glaucoma with age is that intracranial pressure is going down. Now, it wasn't just our study that showed this. There's numerous studies that show that intracranial pressure seems to decrease with age across all age groups. What about some other factors? Well, what about BMI? It turns out that intracranial pressure goes up with BMI. What does that have to do with glaucoma? It turns out that BMI may actually be protective of glaucoma. And Lou Pasquale published a very interesting paper. This isn't that paper, but he published an interesting paper demonstrating that although IOP goes up with an increased BMI, BMI, at least in women, seems to be protective of glaucoma. And then this data out there shows that obesity, even though that it increases IOP, isn't a risk factor for glaucoma. So now I want to pause a second. And I told you the story of these. I had an idea. I brought it back to Rand Allingham. He said, go study it. I worked with Doug Johnson at the Mayo Clinic to study it. And then I came back and Dr. Epstein got all excited about this work. And these three men are gone. They've all passed away before their time in the last 14 years. And my point here, I guess, guys, is that life is really short. We have to go after our ideas and the things that could help us with a zest and a zeal like these guys all did, because our time is limited and we don't know how much time that we're going to get. So fast forward, and I'm going to do my fellowship at Minnesota Eye Consultants with Dick Lindstrom. You know, and he's, in my opinion, one of the real gentlemen of ophthalmology and the most influential person in ophthalmology. And it turns out I did DMEC, a partial thickness cornea transplant on my dad, and I was trained by Dick Lindstrom to do that. And that's the way the world's supposed to work. A mentor teaches us something, and then we use that to take care of the people that entrust us with their care, in this case, my dad. And so I remember sitting down with Dick Lindstrom during fellowship and sharing these ideas with about CSF pressure with him. And he says, okay, John, I believe you. What are you going to do about it? And I said, what do you mean, what am I going to do about it? People are going to think that I'm smart and I'm going to be famous. He said, well, okay, whatever. But I actually like new discoveries to help people. And so I was reading an article a few years later in the Wall Street Journal, and it's talking about how astronauts are losing vision during long-term spaceflight. And I thought, I know why this is happening. And so I emailed the highest ranking doctor I can find at NASA and said, hey, I'm John from South Dakota, and I think I might have an idea of what might be going on here. Astronauts have a syndrome of optic disc edema, globe flattening, choroidal folds, and a hyperopic shift. And this is known as space-associated neurooptic syndrome. It was formerly known as VIIP. And what I believe is going on here is that in space, there's an absence of gravity. So what that causes is fluid shifts in the body. And so our cerebral spinal fluid column is a relatively long column of fluid. And on Earth, as we're all sitting here listening to this mesmerizing lecture, our CSF drains into our caudal spinal column. And our CSF pressure at eye level is lower. But if there's no gravity, it won't drain down, it redistributes up. And now our intracranial pressure at eye level is higher than our intraocular pressure. And we can actually see the effects of this in long-term spaceflight, because when the astronauts walk out to the space shuttle, they look all ripped and cut and their faces are chiseled. And then if you look at them in space, they look kind of chubby in their face because there's all these fluid shifts north of their body. So what you see with this globe flattening, hyperopic shift, choroidal folds, and optic disc edema, look at this intracranial pressure within the subarachnoid sheath of the optic nerve head. It's wildly expanded and it's pushing forward and pushing the optic disc anteriorly. And so we wrote a paper with Bill Morgan and Dao Yu hypothesizing that in space, the normal pressure differential across the optic nerve head, where the IOP is a little higher than the intracranial pressure, is reversed. And intracranial pressure gets higher than IOP, much like we see in IIH, idiopathic intracranial hypertension, formerly known as pseudotumor cerebri. So I'm thinking about this, and I come back and I ping pong these ideas with my partner, good friend, and one of my favorite people, Vance Thompson, as we're sitting here on the plains of South Dakota. And we're talking about what we could do about this. And as we ping pong ideas back and forth, come up with the idea that perhaps we can add positive pressure to the eye raise the eye pressure so that it balances the intracranial pressure and help treat these astronauts in long-term space flight. That quickly led to the opposite thought. If we can add positive pressure over the eye and raise IOP, can we decrease IOP by putting negative pressure in the goggles and releasing some of the atmospheric weight over the eye? Because keep in mind, the optic nerve head separates the pressurized intraocular space from the pressurized intracranial space, and it's only about 500 microns, and this is where glaucomatous damage occurs. So the normal situation is an IOP a little higher than intracranial pressure. Glaucoma's IOP higher than intracranial pressure, and that shouldn't say normal, it should actually say IIH, is when IOP is lower than intracranial pressure. And here's the underlying physics. We measure the pressure differential relative to the atmosphere across the cornea, but we think about it as the intraocular pressure inside the eye. While the intracranial pressure bathes the optic nerve head, and it's really the pressure differential across the optic nerve head, not just the IOP, that likely matters in glaucoma. And it's likely the pressure differential across the optic nerve head that matters to nerve damage in diseases like IIH or on long-term space flight issues like space-associated neurooptic syndrome. So what kind of disease is glaucoma in the first place? Is it mechanical? Is it vascular? Or is it metabolic? Well, the mechanical theory of glaucomatous damage is that the stresses and strains on the optic nerve head are what kills the optic nerve directly. And so as those 1.5 million little axons come through the lamina cribrosa and turn out to the side, they can get kinked by those stresses and strains. The vascular hypothesis is one of ocular perfusion pressure. If the IOP is too high, there's not enough blood flow to the optic nerve. And the metabolic theory is that the pressure differential across the optic nerve head slows axonal transport, and the metabolic needs of the nerve aren't met, and the toxins can't be removed. I'm mostly a subscriber to the metabolic disease, and this paper by Harry Quigley and Doug Anderson, a classic paper from 1978 in monkeys, says why. What he showed is that indeed axonal transport stops or slows at the level of the lamina cribrosa when you elevate the IOP of monkeys, and glaucomatous damage ensues. But what's deeper in the paper is that when you lower IOP for just 4 hours, there is no detectable accumulance of that axonal transport that was stopped or slowed. There's some diminishing even after 1 hour. What that implies to me is that when the eye pressure is higher than the intracranial pressure, axonal transport is stopped at the level of the lamina cribrosa or slowed. As that builds up, eventually the toxins are going to get so great, the metabolic needs aren't going to be met, that there's an apoptotic signal that's sent to one of those axons, and that individual axon dies. Now, if you could normalize that pressure gradient, even for a period of time, and allow the axonal transport to resume, we may protect some of those precious retinal ganglion cells. So what do we know? We know that in the ocular hypertensive treatment study, 10% over 5 years went on to develop glaucoma, and less than half of patients with high eye pressure develop glaucoma even over, I can't remember if it's 20 or 25 years, in the most recent publication related to OATS. And if you treat these ocular hypertensives, you decrease the rate that they convert to glaucoma by 50%. So the point here is that most people that have a high eye pressure don't develop glaucoma, or a certain 5-year period. But if you treat them, you can decrease the number that do convert to glaucoma. And so when you think about the glaucoma landscape, you say, how do we prevent the most people from getting glaucoma, get treatment to the people that need it, prevent adding unnecessary treatment to people that don't need it. And when you look at the whole spectrum of glaucoma, 40 to 70% or so of glaucoma is mild to moderate glaucoma that has a lot of good options: eye drops, SLT, MIGS, etc. 8% of glaucoma is severe glaucoma. These are folks that are at risk of going blind and going blind soon. And then 20 to 50% of glaucoma in the United States is normal tension glaucoma. Patients that have a normal IOP, but they have glaucoma, and that glaucoma is getting worse. And the left side of this graph are the tough to treat people and the people at risk of their lights going out. I'm not overly worried about someone who comes into my office with some mild damage and a pressure of 27 who's been untreated. I can lower that IOP safely and effectively. I'm worried about the person that's got advanced visual field loss or has a normal eye pressure and is still getting worse. They don't have great options. Now, there's a lot of data out there to show that there is a pressure differential that occurs in glaucoma, even in these normal tension glaucoma patients. And this data is from Bill Morgan, showing, and what he did in this very elegant experiment in dogs is he cannulated the anterior vitreous, and then he went into the lamina, and then he went into the post-laminar space, and then into the optic nerve subarachnoid space, and showed that there is a decreasing pressure gradient that actually exists there. If you took a normal monkey and you lowered intracranial pressure, there is a thinning of the optic nerve head that occurs even if you don't change IOP, in one of the better studies that I've seen out there. And then a group out of China led by Rujan Ren, Ningli Wang, and others, and then a non-invasive study performed in Europe showed basically the same things that we saw, that patients that have normal tension glaucoma have the lowest intracranial pressure. Patients with open angle glaucoma have the second lowest. Then there's normal patients, and they have a normal intracranial pressure. And then you have ocular hypertensives that have an elevated and potentially protective CSF pressure. They also showed that there's the translaminar pressure difference is the highest in patients with glaucoma and normal tension glaucoma compared to control. There's studies out there to show that in normal pressure glaucoma, the optic nerve sheath diameter is decreased, implying that the intracranial pressure is lower. Now, there is one study that was published that showed that there wasn't a difference in CSF pressure in normal tension glaucoma versus normals. And now that study was small. It was well performed, but it was small, and it actually did show a little bit of a numeric decrease in intracranial pressure in normal tension glaucoma patients, and it wasn't powered to detect a no difference. So I think that statement, maybe that paper overstated its conclusions a little bit. Okay, so how could we treat a low CSF pressure? Well, if we knew that the CSF pressure was low, it could help us set a target. So a non-invasive way to measure intracranial pressure could be very helpful for us. Because right now, how I do it, I look at this patient and through some method of voodoo and say, here's what your nerve looks like, here's what your visual field looks like, here's what your OCT looks like. I think that your target IOP should be 16. If we knew what their intracranial pressure was, we might be able to set a more precise target IOP for drugs and devices. But there's another approach here when we think about glaucoma as a balance between intraocular pressure and intracranial pressure. And that's how can we dissociate these two pressures? So the normal situation, if you look down at the bottom of this graph, is that we would call atmospheric pressure 0 millimeters of mercury. Now, the absolute atmospheric pressure would be 760 millimeters of mercury. The pressure inside the eye is 22 millimeters of mercury higher than that. So an IOP of 22, that's the intraocular pressure relative to the atmospheric pressure, typically measured across the cornea. And the intracranial pressure would be in absolute terms 769, or in relative terms 9 millimeters of mercury. Now, if you go to treatment of glaucoma, could we somehow decrease the pressure over the eye with a pair of goggles, drawing a negative vacuum, that would lower the pressure in the eye by 10 millimeters of mercury? Now, it turns out we have to dial in more than 10 millimeters of mercury of vacuum to get 10 millimeters of mercury effect, likely because of a new pressure volume relationship that's derived by increased blood flow to the eye and perhaps some dampening of the ocular coats. But the principle is the same. We apply negative pressure over the eye, and the pressure inside the eye goes down relative to the pressures behind the eye, decreasing the pressure differential across the optic nerve head and helping treat glaucoma. So what do I believe glaucoma actually is? I believe that glaucoma is the intraocular pressure minus the intracranial pressure divided by the thickness of the lamina cribrosa, or more accurately, the lamina cribrosa biomechanics, multiplied by time, which leads to loss of retinal ganglion cells and ultimately loss of visual field. So if we, and we're actually developing this product through that company I mentioned called Equinox, discovering really new ways to think about glaucoma and science. But if we put a negative pressure device over the eye, can we create a safe, non-invasive, titratable way to dial in the eye pressure to where we want it to be on some of our most vulnerable and at-risk glaucoma patients? So my question to you is the same question that Dick Lindstrom asked me. What are you thinking about? How are you going to take your idea, turn it into some science, and ultimately translate that into something that will help the patients that we encounter every day treat the diseases or the afflictions that they're facing? Thank you very much, and I'm eager to take questions.
All right. Hi, everyone who has just joined us for our talk, and welcome to Eyes On 2022, more specifically the ophthalmology track. My name is Michael Amar. I'm a vitreoretinal surgeon at Retina Consultants San Diego, and I'll be your moderator for today for the ophthalmology track. And joining me now is Dr. John Berdahl, who just gave us a really interesting talk on glaucoma and CSF pressures and how that relates to intraocular pressures, among other things. Dr. Berdahl, thanks for joining us. How are you doing?
I'm doing great. The background is the same, but I just changed my shirt to a little something that's more casual because I'm on my way to a hockey tournament.
Well, that sounds exciting. It looks comfortable, looks beautiful. Where are you joining us from?
Sioux Falls, South Dakota, and we've had maybe the mildest start to a winter we've ever had. It's been beautiful, actually.
Oh, wonderful.
San Diego, like.
Yeah, I was gonna say, being in San Diego, I love good weather, so I'm all on board with that. We had a lot of people turn in. There's over 10,000 registrants for this talk, in general, this conference, and we have some questions. Hoping we could kind of launch into some of those, if that's all right.
Let's dive in. We're all in this together. Let's try and figure this out.
All right. Well, I really, really loved how you took your story about scuba diving and just kind of a moment in time and a thought in time, and turn that into a hypothesis and really an entire field of research. Could you walk us through how you take an idea and turn it into innovation? I feel like that's a complicated process for a lot of people.
Yeah, and it's a complicated process for me too. It's complicated. And I think that, the first part is allowing your mind to be fertile and allowing lightning to strike, right? So many things have been discovered in other areas of medicine or other, professions and fields that we exist in, engineering, physics, whatever. And most of the time it's about connecting the dots, or when something doesn't make sense, you ask yourself why until you can make it make sense. So for example, when we were scuba diving, I thought, how is it possible that I could have all this pressure on my eyeball and still perfuse my eye and not get glaucoma? And I'd think about it as just the pressure inside the eye. And so taking that and wrestling with it and wrestling with it and wrestling with something that doesn't make sense can lead to a deeper understanding. Then you go from a deeper understanding to kind of the theme of the talk is, what are you going to do about it? And And that's actually really hard, because I think that if we knew how high the mountain of innovation and entrepreneurship was to climb, we wouldn't start climbing. So don't look at all the way at the top of the mountain. Just if you keep waking up day after day thinking about the same problem, take one step in front of another. Get some mentors that have done it before. You don't even need to know. Reach out to somebody you think you trust and say, hey, I got this idea. What are my next steps? And it's going to be something like look up some intellectual property. First of all, is this a business, or is it a product, or is it a feature? Get some intellectual property around it if it's a product or a business. Test it fast, fail fast, and be able to move on. But if it seems like it's real, then you go out and you surround yourself with people that know what you're doing. And unlike what doctors usually do and think they can do everything themselves, really surround yourself with people that are experts in what they do: raising money, intellectual property, running a business, marketing, and take that stepwise approach of taking, an idea, turning an idea into a product into a business, and ultimately something that can help people. And the end goal, and the only way it's sustainable, is if it brings fair value to everybody: patients, doctors, payers, and the company. Otherwise, it evaporates.
Well, talking about that a little bit, glaucoma is a field where we're seeing a lot of innovation, and we've come so far from where we were 10, 20 years ago, helping a lot of people we couldn't help before. But I still feel like we have unmet needs in glaucoma, and where do you think those are?
Yeah, for sure. I'm cornea trained, I'm glaucoma trained, I do cataract, I do refractive, and it seems like things go in waves, right? All the cataract innovation. Okay, and then there was retinal along with retinal injections and anti-VEGF.
Yeah.
And then we're doing DMAC. And then we're doing MIGS. And MIGS has probably made the angle of the eye the most crowded anatomical space in the body. And it's really been great. But it's pretty easy these days to take good care of mild to moderate glaucoma. Lasers, drops, MIGS, take your pick. Where the unmet need exists, unfortunately, is in the real most vulnerable patients. Those severe glaucoma patients, normal tension glaucoma patients that don't have good, safe ways to get eye pressure down. That's where the real unmet need still exists. And I think that that's where our attention in the glaucoma space needs to be focused.
Got it. And great points. You talked a lot about CSF pressure, and that was a big focus of your research and some of those innovative ideas you had. So, I mean, if you had to summarize it, how would you say, if someone were to ask you, CSF pressure relates to glaucoma beyond eye pressure?
Yeah, how I would say it is, there's two sides to the coin of the optic nerve. It's exposed to the IOP and it's exposed to the ICP. And when those two are in homeostasis, we're in a good spot. But if we're not, the eye pressure is too high or CSF pressure is too low, you get glaucoma. Or reverse it, CSF pressure is too high and IOP is too low, you get IIH, pseudotumor, or hypotony. And we want to be in homeostasis.
That's a nice way of putting it. And talk to us about those goggles. How did the goggles work?
Yeah, so basically it works like this. If I put my thumb on your eyeball, pressure in your eye is going to go up. When I take my thumb off, pressure is going to go down. Well, we're pressurized human beings, and the weight of the entire atmosphere is pushing down on our whole body. And if we can simply release some of that weight, the atmospheric thumb, if you will, we release some of that weight off the eye, the pressure in the eye is going to go down, but it's not going to change CSF pressure. It's not going to change blood pressure. And so the pressure in the eye is lower relative to every other pressure in the body. And we know that happens because of your profession. Because when you put an air bubble in somebody's eye after a vitrectomy, you say you can't go to the mountains, you can't get in an airplane. Why? Because as the pressure goes down in the eye, the air bubble would expand. And so we know physiologically that the pressure in the eye would go down if the local atmospheric pressure was changed over it.
Yeah, makes total sense. And actually, we have an interesting question from the chat. It's, if raised intracranial pressure patients, so someone with increased intracranial pressure needs a decompression procedure to protect the nerve, or for whatever reason, would that cause a higher chance of glaucoma due to the change in the differential postoperatively? So I guess if you have high intracranial pressure, let's say you do a shunt or something and you drop the intracranial pressure really low, can you increase the risk of glaucoma?
Great question. And the answer is yes. And that's been demonstrated. There's actually been studies on patients that have received ventricular peritoneal shunts, typically for normal pressure hydrocephalus, where that exposes or causes glaucoma. And so it's definitely known that can cause glaucoma. And, experimentally, they've done this too. I think I maybe mentioned it in the talk, but they took monkeys that had normal eye pressure, normal CSF pressure, lowered their CSF, and they got glaucoma.
Yeah, and it makes sense. I mean, I think that's what's really fascinating about your idea. It's taking advantage of all these different physiologic systems, which I think we tend to think of as separate, but in a way they're all intertwined in a way that makes perfect sense.
And interestingly, Mike, I heard something once that the vast majority of innovation comes from people in training or within 5 years of being out of training, of new big ideas. And I bet I wouldn't have had that idea at my old gray bearded age of 45, because, we put ourselves in our boxes. But I was a first year resident. I didn't know any better. And so to those young doctors out there, your naivete is an asset, and use it. Go after stuff. We don't know what we're talking about. Challenge it, make it better.
Yeah, that's great advice. And I love that, because it's true. I think as we go further along, we get less creative in a way, and I think that when we're younger and we've seen less and been taught less to be in the box, you come up with a lot of interesting ideas. So that's wonderful advice. Thank you. All right. Well, we've taken a lot of your time. Wonderful talk. Really interesting stuff. People were loving it in the chat. We're gonna let you get on your way and have a couple of housekeeping announcements. I know you said you're making it over to a hockey tournament. Is that right?
Yep. Go Flyers.
Go Flyers. Any last bits of advice or anything for anyone out there?
Guys, I think that my last piece of advice would, and I kind of said it at the beginning, we're all in this together, right? I mean, we're lucky to take care of the most precious sense in the body. We're in the best specialty, in the best profession in the world. And we're in this together with a noble purpose. And a lot of our energy is spent frustrating each other, fighting with each other. And let's just try to remember we're all on the same team and go forward and leave everything we touch a little bit better.
Thanks, Dr. Berdahl. Great words. Appreciate it.
Thanks, everybody.
Right. And then to everyone sticking around here, just a couple housekeeping things and a little bit of commentary. In between talks, be sure to visit the Innovation Zone and the exhibit halls. There's lots of interesting products, information, prizes, a ton of things happening throughout the day. There's many different ways you can win prizes. One of those is the raffle. And just for those of you who are tuning in, there's going to be 2 raffle codes for today. The first one is keratitis, and the second one is nevus. We'll bring those up at each of the talks here on our ophthalmology track as we go on through the day. There's a little bit of a break here, and then we'll see you back for our next talk in a little bit. Please enjoy the rest of the educational things going on, and we'll see you a little bit later. Dr. Berdahl, thank you again.
Thank you so much.